triple-negative breast cancer. This is a source of confusion and perhaps fear and anxiety in patients diagnosed with the condition. To alleviate some of these concerns, in this video, we'll explore what triple-negative breast cancer is, or TNBC for short, together with the options for surgical treatment and the scientific data supporting each operative strategy so that women with TNBC can be empowered to make the best treatment choice for themselves. Please note that the information presented here is solely for educational purposes and is not intended as a substitute for a medical consult. Do see your doctors for a discussion about your specific circumstances and treatment planning. That said, at the end of the video, I will give a brief summary of the relevant data which you may wish to discuss with your doctor to help you make an evidence-based surgical treatment decision. What is triple-negative breast cancer? This is a subtype of breast cancer where the cells do not stain for estrogen receptors, progesterone receptors, and the human epidermal growth factor receptor 2. They are abbreviated to ER, PR, and HER2, respectively. These three protein receptors are either not detected on the surface of the cells or not overexpressed in triple-negative breast cancers. Why is this important to know? When hormones or any triggering molecule connect with their specific receptors, it initiates a cascade of events in the cancer cell which causes it to multiply. We now have medical therapy which effectively block the connection of hormones and molecules to the receptors that are external to the cell, thereby preventing cancer cell multiplication. However, these medications are not efficacious for triple-negative breast cancer, as there are very few, if any, receptors on this type of cancer cell. TNBC is thus more challenging to treat, especially from a medical point of view. It is also an aggressive form of breast cancer, which makes therapy doubly challenging. Several specialists form a team to coordinate therapy for women with triple-negative breast cancer. But as a channel dedicated to early diagnosis and breast cancer surgery, we will focus on the operative treatment of TNBC in this video and allow other specialists to discuss their roles elsewhere. Bear in mind that all specialists, the surgeon, medical oncologist, and radiation oncologist, have equally important roles in the treatment of breast cancer. With that understanding, we will concentrate on the surgical aspect of therapy. You may already know that there are two broad categories of surgical therapeutic options: breast conservation treatment or mastectomy. Breast conservation treatment, or BCT, is the combination of breast-conserving surgery and subsequent radiotherapy. Breast-conserving surgery may also be referred to as lumpectomy, partial mastectomy, or segmental mastectomy. This is the process whereby the cancer is removed together with a rim of normal breast tissue around it, leaving the rest of the uninvolved breast intact. Surgical techniques are often applied to restore the breast to a reasonable cosmetic appearance. Optimally, I would aim for a cosmetic result similar to the one we see in this patient, where this is the scar which remains after surgery, with the faint line which demarcates the zone of hyperpigmentation as a result of radiotherapy. Mastectomy involves the removal of the entire breast, and this may be the appearance if a patient chooses not to undergo reconstruction. There is also an option not only to have a single or unilateral mastectomy, but also to have a double or bilateral mastectomy, and to have reconstruction after. The topic of bilateral mastectomy has been discussed in other videos. In this video, we will focus on discussing mastectomy in relation to triple-negative breast cancer. Let us now look at the scientific data available in medical literature relating to the outcomes of surgical treatment. In most of the studies cited, there will be a comparison between breast conservation treatment, or BCT, and mastectomy. I'll begin by putting this comparison in context. At a recent St. Gallen breast cancer conference, an expert panel agreed that breast conservation is the treatment of choice for the majority of women with early-stage breast cancer, which includes women who have been diagnosed to have stage 1 and stage 2 breast cancer. One of the most important parameters that doctors analyze when comparing outcomes between two different treatment modalities is overall survival. This represents the proportion or percentage of patients still alive at a particular point in time after treatment. This is often calculated at 5 or 10-year timeframes. Researchers often look at other outcome parameters apart from overall survival. Breast cancer-specific survival is derived by excluding in the calculations pertaining to the denominator the number of women who have met their demise from causes other than breast cancer. This percentage is therefore often higher than overall survival. In addition, disease-free survival may also be a measure that is evaluated. This refers to the proportion of women still alive without any cancer detected. The first study we will review was done by this team of doctors in the United States who analyzed data from the surveillance, epidemiology, and end results database for women with early-stage TNBC. They came to the conclusion that lumpectomy followed by radiotherapy is associated with better overall survival and breast cancer-specific survival in early-stage TNBC patients. These are the other parameters which doctors study when evaluating the efficacy of different modalities of treatment. Local control is used in the positive sense and refers to the proportion of women still alive without any evidence of recurrent disease in the treated breast. Local recurrence is when cancer reappears in the treated breast. Often, the term loco-regional recurrence, or LRR, is used to denote reappearance of disease either in the breast or in the armpit on the same side. In an analysis of patients treated across their country, members of this German breast group found that breast-conserving surgery following neoadjuvant or preoperative chemotherapy was not associated with an increased risk of loco-regional recurrence, or LRR, in patients with early-stage TNBC. In fact, the use of BCS was associated with superior disease-free survival and overall survival compared to mastectomy. They therefore concluded that TNBC subtype should not be used as an argument to withhold BCS, followed by adjuvant radiotherapy in eligible patients. Their data supports the use of breast conservation treatment for early-stage triple-negative breast cancer. Independently, there was also a Korean study which had similar results in that breast conservation therapy achieved better loco-regional recurrence-free, disease-free, and overall survival rates compared with mastectomy. This is an older study by a team of doctors from Canada published in 2011, which found that women with T1 and T2N0 TNBC treated with modified radical mastectomy, or MRM, without radiotherapy have a significantly increased risk of local and regional recurrence compared with those treated with breast conservation treatment. To clarify, T1 and T2 cancers are tumors up to 5 centimeters in dimension. N0 refers to no metastatic disease detected in the lymph nodes in the axilla or armpit. So we have known for some time that breast conservation treatment is not inferior to, and in fact may confer improved survival when compared with mastectomy in women with early-stage triple-negative breast cancer. At this point, I would like to move slightly away from the sole focus on TNBC and discuss two unique circumstances for consideration when making a decision for breast cancer surgical treatment in general. We will look at the data for young women diagnosed with breast cancer and for those who are found to have high-risk hereditary genetic mutations and how they may apply for a patient's decision-making. This team of researchers from Kaiser Permanente in California studied breast cancer recurrence by subtype in a contemporary cohort of young women. The important findings in this study were firstly, that the highest 10-year cumulative incidence of recurrence was observed among those with high-grade hormone receptor positive, with HER2 negative or hormone receptor negative, with HER2 positive invasive tumors. This means that triple-negative breast cancers did not confer increased risk of recurrence in young women. Secondly, they found that the type of surgery had no significant association with recurrence across all subtypes. We move on to address the issue of women with a high-risk genetic mutation, like the BRCA gene. A meta-analysis is a statistical method employed to combine the results from several studies in an attempt to generalize the findings. This group of doctors did a systematic review and meta-analysis and found that survival outcomes following breast conservation treatment is comparable to mastectomy in BRCA mutation gene carriers. However, the risk of locoregional recurrences increased. In addition, over 10 years, there is an estimated 14% risk of developing cancer in the contralateral or opposite breast. So women with high-risk genetics who do not wish to follow high-risk surveillance regimens or have concerns regarding risks of locoregional recurrence or contralateral breast cancer development, bilateral mastectomy may be an option. In summary, expert consensus states that breast-conserving surgery, usually followed by radiotherapy, is the surgical choice for the majority of patients with breast cancer, regardless of subtype. Current data specific to triple-negative breast cancer shows that overall survival are equivalent, if not higher, with breast conservation treatment when compared with mastectomy for eligible non-genetic mutation carriers. However, women who are genetic mutation carriers and are diagnosed at an early age with TNBC may wish to consider bilateral or double mastectomy as an option, bearing in mind that it may not confer overall survival benefit and might be associated with an increased risk of surgical complications. A link to a series of videos on double mastectomy are available in the description below for a more comprehensive discussion. I hope that the topics discussed in this video have provided more clarity about the surgical treatment of breast cancer. If you have found the information in this video helpful, kindly like, comment, share, and subscribe as a form of motivation for more similar content. If you wish to have a further discussion about the articles presented, please visit the Just Medicine Breast Cancer Surgery website and submit a request. We look forward to continue helping women with breast cancer choose surgical treatment that helps them live longer and live more. Until our next video, take care.